My portion of today's program is to talk about relapse in MS, and I've decided to discuss optic neuritis. Dr. Green has already mentioned several factors about optic neuritis, and I'll continue on with that. It's a very clearly recognizable relapse in MS and quite important, as we'll see. So a little bit of background information, and before we launch into the details of the program, the two objectives that I'd like you to at least go home with is to recognize the sign and symptoms of optic neuritis, as well as be able to identify the treatment that we use in an acute relapse of optic neuritis. And so some background before we get into the details. This represents a normal globe and optic nerve. And on the opposite side, you can see that there's some inflammation shown by the different color of the optic nerve. The optic nerve is one of the cranial nerves. There's 12 cranial nerves in the brain, and the optic nerve is cranial nerve number 2, and it carries visual information as well as we've more recently learned. It does participate in processing information as well, but it carries information about brightness, color, and contrast from the vision that comes in through the pupil into the back of the retina and into the optic nerve. So there are two optic nerves, one on the right and one on the left, and they each hold 1.5 million fibers. So that sounds like a lot, but we really need that the way that that's been, our body's been designed is such that we can see a lot of detail and a lot of information because of that. From the optic nerve, that visual information gets passed into the brain for processing. The optic nerve is actually considered central nervous system tissue because it's covered with a myelin sheath. And this myelin sheath, you've heard a lot about myelin in reference to MS. Myelin is produced by another nerve. It's called an oligodendrocyte. And in the central nervous system, myelin is made from oligodendrocytes, and it wraps the nerve fiber, or the axons as they're called, from each cell. There's a long axon. And so myelin wraps the optic nerve like it does other nerve fibers in the brain, and that's why it's central nervous system. And that wrapping of myelin allows signaling to be conducted very quickly in the central nervous system. MS is considered to be an autoimmune disease, and it attacks nerves in the central nervous system. So the same thing can happen to the optic nerve. With an autoimmune attack, it attacks the myelin, or this coating around the optic nerve, and then therefore signaling is disrupted. It's slowed down, or it's blocked, or it can actually just be loss of conduction if the nerve fiber itself, in addition to the myelin, is damaged. Thankfully, our bodies have a mechanism for remyelination, and you've probably read that science is now looking into therapies that can help remyelinate, but the body can do this to a certain degree. And so when you have a relapse, or what's very characteristic of relapses, or our anticipation when somebody has a relapse, is that you do have recovery. It may not be full, but there is some recovery. So as in optic neuritis, there is typically recovery from that optic neuritis. Now, because it's central nervous system, other than the oligodendrocytes, the central nervous system has very little mechanism, as we understand today, to regenerate itself. And because of that, if there's severe loss for example, in the optic nerve, or for that matter, any place else in the central nervous system, meaning the brain and the spinal cord, you can have permanent damage. Permanent damage along the optic nerve is concerning because it could lead to visual loss, and if there's too much damage, possibly even blindness. But at least put your minds to rest in terms of that, because as we'll see, there's usually good recovery from optic neuritis in MS. Optic neuritis is common, and that's one of the other reasons why I'm focusing on this as part of the talk today. It's a common cause of visual loss in young adults, and young is considered at least up to 50 these days, so that's reassuring. And the incidence is 5 per 100,000, And prevalence, which is how many cases exist at any one time, that's 115 over 100,000. So those numbers may not seem like a lot, but that's considered common. And in addition to the prevalence of it, it's common as a first symptom of MS. And so in about 20% of people who develop MS, their first symptom is one of optic neuritis. So 20%, 1 in 5, that's substantial. However, it can also occur at any time within the course of MS. If you haven't gotten it, it's, MS, Dr. Green likes to call it a sneaky disease. It can come later on. Now, the frequency or the rate at which it occurs in those people with MS over a lifetime is 66%. That's rather high. Some people may have one bout of optic neuritis and then have another episode, or what we call a recurrent episode. That's the nature of relapses. They come and then they go and then they come again. So the frequency can be high. And what are the signs and symptoms of optic neuritis? A symptom is something that you feel. It usually starts with eye pain. The definition of optic neuritis includes vision loss and eye pain. Thankfully, it's usually affecting one eye only. It can affect two, and it's not something acute that happens, in 2 minutes, all of a sudden you have some vision loss. It builds up over time. It worsens over hours and many times over days. And the vision loss can range. There's a continuum of this. It may be very mild vision loss, such that it feels like there's a little saran wrap over your eye. The vision may be dim or dull or fuzzy. And sometimes people really can't see at all, and that may progress. They may progress such that the vision is blurry on the first day, and then in 2 or 3 days it's dim, and then maybe they can just see the outlines or shadows of things, and sometimes only people can see some light if you shine light directly in the eye. So those are the symptoms. Usually the eye pain comes first, and then the vision loss. The vision loss may not be everything that you see. It may just be a portion of what you see. Typically, it's the upper half of the vision. Sometimes it can just be in the center, and so it feels a little bit like a migraine for those of you who've had migraines where you have some vision loss. So you can't see in the center, but you can see in what some of you may call your peripheral vision. And then actually times the vision loss may be 1/2, so that you can see nose over to your ear, or maybe you can't see from your nose to the other side. So it may be just 1/2 affecting what we call a vertical meridian, or 1/2 affecting a horizontal. All of those are possible. When you have a neurologic exam, and especially, I know when you come into my office, you may be wondering, why am I showing you fingers? What is the purpose of this? Well, it's to test your vision. So we test for visual acuity, and by that I usually am testing how well you see contrast by showing you a visual card and asking you to read the smallest row of numbers you can, and each row gets a different designation. We do visual fields in which we do show numbers to see if you're missing any of those areas that I just talked about. If you can identify the fingers as we show them around, then it's very reassuring that you have preserved visual fields. And we do something called a pupillary light reflex, or the swinging flashlight test. That gives me an indication how well that optic nerve is functioning. If one pupil opens up more than the other, it's called an afferent pupillary defect. It gives me an indication that there's something going on. And of course, the fundoscopic exam, which is a direct way of looking at that optic nerve. You may also be wondering, why am I shining that light in your eye? What am I looking for? I can actually see what's called the head of the optic nerve, and see, I can look at the color, I can look at the outside edge called the margin and see if it's nice and sharp. And that's considered a little piece of central nervous system tissue. So I'm actually looking at part of your brain when I'm looking in the back of your eye. How else do we diagnose optic neuritis? Well, so far we have the signs and the symptoms of it. We have my exam. And just as in all other aspects of multiple sclerosis, MRIs have come to be a large part of diagnosis. In terms of MS being a sneaky disease, optic neuritis doesn't always show up on an MRI. And we order the MRI when somebody has those signs and symptoms, not merely to detect the presence of optic neuritis, but namely, one, to give us some indication whether this is a person who, if it's a first event, may develop MS in the future, or to see if there's something going on with their underlying MS, and perhaps to rule out something else. Optic neuritis is not the only cause of vision loss in a person, so we don't want to jump to that diagnosis before we can rule out something that would be important to treat. But on occasion, we can see that inflammation, just like we saw in that cartoon. So I'm going to give you a quick lesson in radiology. So the first thing is, this is the brain, okay? And on an MRI, brain tissue is gray. It's either light gray or dark gray. And usually, this is what's called a coronal view. So that's the front of the head going to the back. And these funny looking things are actually the orbits of the eyes. And in the orbit of the eye lies the optic nerve, one on each side. Here's one, and then here's one. So in looking at an MRI, and some of you may get discs when you go to the radiology department and open them up on your computer and try and look at them. The first thing we can always look for is the right side the same as the left. Is there some difference? If there's a difference, well, then there's probably something that's considered not normal. So in optic neuritis, there's inflammation, as we learned, and so the optic nerve may look inflamed. On MRIs, usually that means brightness, extra brightness. So is this one bright? How about that one? No. Okay. So when we look at MRIs, it's like looking at mirror images. So this side happens to be the right side and this the left. So here we have inflammation or evidence of optic neuritis in the right eye. So that's a quick radiology lesson. Here's another MRI. This one is kind of subtle, but here you can see there's just a hint of brightness over here on now the left side. This is a different view. This is not the frontal view. This is what we call an axial view, or I like to equate it to making slices across an orange going along the direction of the equator, and so we get slice by slice by slice, or you can call it a top-down view. Again, this is the right side, this is the left. This is the globe of the eye. This is the optic nerve that comes from one globe, the optic nerve that comes from another globe, each one carrying 1.5 million fibers. And here there's a little brightness, so possibly there's optic neuritis in that eye. With an MRI like that, I would really need to clinically correlate it with the person's symptoms. Here's another MRI. Now, do you recognize the eyeballs again, the globes? And what's this here? The optic nerve, that's right. And here's another optic nerve. And if you can also look, for the most part here, we don't see lesions of MS, but this is not necessarily the best sequence to look for lesions. I mean, there might be a little spot up in there. But here you can see that, again, there's a little brightness on this picture over on the right side. Now, if somebody has optic neuritis and either the eye doctor or myself order an MRI, if we see findings like this, and you may have seen your own MRIs with white spots, then we can say there is evidence of MS. These are fairly typical MS plaques, damage in the central nervous system or demyelination due to that autoimmune attack. And then if it's a first event, and Dr. Green went through the various types of descriptions of MS, if this were an optic neuritis or what could be called a clinically isolated syndrome, but with evidence of MS already in the brain, we can think of that as a clinically isolated syndrome. Really, sometimes semantics enters into how we phrase this, but because there's already demyelination, one would feel quite confident, a physician, for example, a neurologist, myself or Dr. Green or somebody specializing in MS, in really thinking that MS is already established in this patient because we have MRI evidence of plaques in addition to the first episode, clinical episode that they're having. So one could call that technically a clinically isolated syndrome, or as some do these days, a form of early MS. It's because we now have treatments that we start right at these first events. This is a very clear slide. This was taken from the Neurology Journal. And here you can see the arrows. So I don't even have to explain this one. So what do we have over where the arrows are pointing? Are we on the right side or the left? Right. Excellent. We're looking at the optic nerve, right? And so we're going to look from one side to the other. So do you see a difference between this optic nerve and this one?
Yes.
Yes. Okay. So this one is bright, and so is this. This is the same individual, but two different sequences. This one has the gadolinium, which when we do MRIs in people with MS, we always ask for gadolinium unless there's a problem with your kidneys, and because it shows acute inflammation very well. Now, optic neuritis is always not a product of MS. There are other disorders that can cause optic neuritis, and we'll get into that a little bit, but I'm bringing it up at this particular slide because this slide happened to be from a patient who had neuromyelitis optica, which is a disorder that can almost be considered a kissing cousin of MS. It's not exactly MS. We treat it with different medications, so it's important to identify it as a different disorder. We have a test for this one, thankfully, and it can come with optic neuritis on one side and even on both sides, and a relapse can result in substantial loss to vision. So when we see bilateral optic neuritis, we look very carefully for that particular disorder. So let's jump to treatment now. We've gone through recognizing the signs and symptoms. We've gone through the clinical exam findings, and now we'll get into treatment. So there is some controversy in the literature in the necessity of treating optic neuritis, and it can be somewhat physician dependent, and even ophthalmologists may take a different approach from neurologists. But since this is a talk on relapse, and optic neuritis is an excellent example of a relapse, the treatment in terms of using steroids certainly apply to other relapses as well. So if we went ahead and decided to treat for optic neuritis, there was a clinical trial that was done, and patients were looked at for 15 years. So we have very good data from that. It's called the Optic Neuritis Treatment Trial. And the patients who did the best had 3 days of IV methylprednisolone. That's 1,000 milligrams a day for 3 days in a row. In that trial, it was divided up into 4 doses over the course of the day. But in today's day, we usually give 1 dose at a time. We found that people tolerate that very well. And then followed by an oral taper. The taper that was used in that particular trial was 2 weeks of high-dose steroids based on your weight, and then a quick taper off. And in today's world, we found that that part of the treatment is not set in stone, and so depending on the neurologist, you may get a 5-day taper or a 10-day taper or a 2-week taper or a 7-day. It's a little bit of the art of treating relapses, but we fairly well stick in optic neuritis to treatment with IV methylprednisolone, 1,000 milligrams a day for 3 days. And the reason why it's a little bit controversial is that the treatment doesn't necessarily correlate with any difference or change in your recovery, your ultimate recovery from optic neuritis. Because I'll show you in a couple of slides that, as I mentioned before, the recovery is generally good from optic neuritis. The use of steroids will hasten or speed up that recovery. So somebody who already has poor vision in the fellow eye, or somebody whose job requires good vision, or somebody who does a lot of driving and doesn't really want to travel with monovision, there's certainly rationale to use IV methylprednisolone. And that increased recovery can be quite beneficial. If the optic neuritis, as I mentioned, is very variable, such that it just can be very mild to very severe, I might be more inclined to use it in a severe case and hold off on the milder case, because I'm going to be considering the benefits and the risks of methylprednisolone. It's an IV drug. It can be associated with some side effects. But generally speaking, and in my practice, I would go ahead and use IV methylprednisolone if the visual acuity was, for example, worse than 20/40. If it's better than 20/40, that vision is considered just a mild problem, and it's likely that that's going to really recover nicely. Recovery starts within 2 to 3 weeks, and we know that even with people who have worse than 20/200 vision at onset, so that's quite poor. That's way up high on the what we call our near card or the Snellen chart. In 85% of people, they recover back to that mild degree, better than 20/40. Now here, just take note that about 95% have significant improvement by 1 year. So the recovery takes some time. It's not going to happen overnight. And by good recovery in this sense, it's better than that 20/40 number that I just cited. Most, not all, but most people return to 20/20. So more than 50%, it's about 2/3 of people return to 20/20. Even when the vision recovers, that's normal vision, sometimes people say, you know, my vision just really still isn't right. My color vision is not quite as sharp. If I show them something red, maybe it looks a little pinkish on the affected eye rather than the bright color red. Their visual field, they may sense, oh, there's just a little portion that I'm missing over there on the side. And sometimes that contrast can be decreased. So if you're reading a newspaper or you're reading something on your screen, you have to pump up the contrast to read it a little better. Some people may have noticed if they take a hot shower, if they get on their treadmill, or if they start exercising, their vision may temporarily decrease. That's common. There's been a little damage in that optic nerve, or maybe instead of 1.5 million neurons that are working equally well, maybe you now only have 1.4 million neurons. So if there's a little bit of damage there, then the rest of that nerve has to serve the function of the normal nerve, or conduction slows down, and so the body doesn't really like to operate under extremes. And this applies to all relapses, and just as we heard in the talk on pseudo-relapse. We have a normal body temperature. Most people it's 98.6, but if you fluctuate in your body temperature, if the body gets too hot or too cold, it's really not going to work at its optimum sense. So if you raise up that body temperature either by exercising or being in very hot weather or having a fever, the conduction is just not going to be as good. So the vision may suffer during that time, but you're not doing permanent damage. It will recover. So now that we've gone through the basics of this, let's do a case study. And I kind of constructed one or made up a case. So instead of Susie, I'll use Jane. Okay. So Jane is a 24-year-old young woman who noticed some eye pain on her left eye, and this was going on for about 2 weeks. And she knew it wasn't quite normal, but she had a history of migraines, and so she thought, okay, I'm just going to ride this out and see what happens. And this is a fairly typical scenario, but in the meantime called up her eye doctor to make an appointment in case You know, she was trying to be proactive in case she needed to go in and see if the pain didn't go away. And so she went to her eye doctor, and the exam there was good. The visual acuity was fine, the contrast was fine. So very prudently, the eye doctor said, you know, you do have that eye pain, but let's just watch and wait it. And in the meantime, let's order an MRI. Because that eye doctor knows eye pain in a young woman can be concerning, and it can take, you know, a day or two to get an MRI. And so the eye doctor, him or herself, was very proactive and ordered the MRI. And the patient went home, and before getting the MRI, the eye pain actually went away. So she's thinking, okay, I'm out of this hot water, you know, I'm not too worried. And then what do you know, the very next day, she wakes up and she has loss of vision in that left eye. So here we have our typical scenario, right? Pain comes before the vision loss. The pain goes away. And then there's some vision loss. So thankfully, that MRI was already ordered, and she makes her way into the radiology department. The ophthalmologist ordered, very astutely, an MRI of the orbits, fat suppressed, like the coronal one that we saw, so we can clearly see the optic nerve, and ordered an MRI of the brain so we could assess for any lesions in that brain. And so our young lady, Jane, goes and has her MRIs done, and then I'm sitting in my office, I'm in between patients, and I get a call from the ophthalmologist. Okay, I had this patient, she came in to see me, she had no vision loss, but she had eye pain. I ordered this MRI, and it's showing something a little suspicious here. Can she get in to see you? So I say, fine, I have an opening, not today, it's, you know, my office is full, but I have an opening tomorrow. Send her over, but could you just see her today? So the ophthalmologist says fine, and Jane goes back to the ophthalmologist, and lo and behold, her visual acuity now in the eye doctor's office, using all that fancy equipment, not my little card, is now 20/60. So it's worse than that 20/40 that we have, and lo and behold, also she has a little visual field defect in that left eye. So here we have the signs and symptoms. We have now the confirmation by the eye doctor and the MRI, and we can easily use one of the MRIs that I showed you earlier. You have it in your notes, where we see enhancement in one of those optic nerves. And not only is showing the enhancement, but is showing not two of those plaques, but just one plaque. So she comes to my office, and my office exam is fairly well the same. I do my fingers, I show her my card, and the pain is gone, but she has the visual loss, and she's got that MRI. And so we sit down and we have a long talk. And I go through the fact that now she's had her first relapse being an event of optic neuritis, but she has indication in her MRI that MS is a high likelihood in her case. In fact, so likely that we can go ahead and treat her for the acute relapse, and we're also going to discuss treatment for MS itself with one of the drugs that we have good data for that we use in this CIS, but also really the first event, because multiple means multiple times and multiple places in the brain. And so we don't really, so for every multiple events, there's always the first event. That's what a CIS is. It's the first event of something that's going to be multiple. And so I went ahead and I treated her right in our own infusion center, and she was seen by our nurses who gave her the infusion. We did IV methylprednisolone to Jane for 3 days in a row, and they packed her up with her catheter and some Coban or something, stocking net around it. So we gave her a few days off of work so she didn't have to go into work with her catheter in her arm. And I gave her a steroid taper, and she recovered quite nicely. In fact, she recovered within just about a month's time. So her vision came back to 20/20, and the eye pain was gone, and we got her on an MS medication. So that's somewhat of a conglomeration of a made-up case and a true case, but that's a good outcome for this kind of event. So bear in mind, optic neuritis is not the only cause of vision loss in MS. If you have MS, really it's best to not sit on it, so to speak, but to go to your eye doctor. It could be glaucoma, it could be an infection, it could be something else going on in your eye that needs assessment. And so I thought I would end the program with the 2,000-pound pumpkin contest because of Halloween. And it's hard to appreciate that this is a pumpkin, and it's hard to appreciate that it's 2,000 pounds, but that's what I read on the internet. And I thank you for your attention, and if you have any questions, I'd be glad to answer them if I can. Okay, here's a very good question. Is IV methylprednisolone given as an outpatient? Oftentimes it is. In my own practice, just like Dr. Green, I really want to see that person first before I start prescribing IV medications. And if it's a young, healthy person who's never had IV methylprednisolone before, my inclination is to give the first 1 or 2 doses in our own center so we can watch that person, we can take some vital signs and know that there's no adverse event to it. If it's somebody who's a little bit older or has diabetes or high blood pressure, then I may seriously consider putting them in a hospital setting because methylprednisolone does have some side effects, as I mentioned. It can easily raise the blood sugar. And if it gets if it gets 200 or something like that, I'm not too worried because I know it's going to come down without that prednisone. But if somebody has diabetes, it could easily go into the 400s, and then I'm not comfortable doing it on an outpatient basis. Do I have to give additional treatment to improve vision since it can take up to a year? Another good question. The treatment, there's really not time is the other treatment. And so once we give the steroids, there really is, those are the most powerful anti-inflammatories we have for this case. I may, if the vision is not recovering well, I may have somebody go to a low vision clinic to help accommodate to that visual recovery or do something like that. When you have a relapse, is there any way to know how long it will last? Another excellent question. If you already have established MS, perhaps how your past behavior may be some indication of future behavior. If it's a sensory relapse, those are less worrisome and probably you probably would have a quicker and faster and more full recovery from a sensory relapse than if it's motor. If it's involving the brainstem, those are often difficult and take long to recover. That would be something like double vision is a function of the nerves in the brainstem. So those can take time. But usually by 6 months, we expect recovery. And after 6 months up to a year, there can be recovery. If a relapse is going on more than a year, then it's really unlikely you're going to have recovery more than you already had. In chronic MS, optic neuritis, does this cause cataracts or glaucoma or the reverse? Not typically, but the use of IV steroids the use of steroids, it's usually chronic prednisone, can increase the risk for cataract. I think that's where I'm going to end it for right now because some of these questions are actually, they would take more time than 1 minute that I have left. So I thank you for your attention and have a wonderful rest of the day.